Hello, everyone. Thank you for joining. Today's session is going to look at corneal dystrophies. Generally, from a clinical point of view, you are invariably going to come across somebody with a corneal dystrophy. You'll typically probably come across either epithelial or endothelial. They're probably the more common in terms of clinical practice. We will also probably come across some stromal ones, especially on a corneal firm. And then for your exams, these are pretty high yield. So for the part two written and the part two oral, these are really, really easy points to pick up. So it's worth sort of understanding the general principles behind the dystrophies, how they're divided, and generally how they're treated and what we expect them to cause from a symptom point of view. Some of it is pretty easy to work out, but some of it is just rote learning. So in terms of inheritance, genes, etc., sometimes you just have to sit down and just learn those for your exams. But I'm going to talk about some exam tips later on near the end of this in terms of how you can remember some of the stuff related to corneal dystrophies. So essentially, like I said, you're thinking layers. The dystrophies will affect different layers of the cornea. And you just start from the front, going to the back, and then we're going to go through the layers and talk about the different dystrophies that you should know. I'm not going to, it's not an exhaustive list. I'm not going to go through every corneal dystrophy known to man, but I'm going to go through the main ones that you're probably A, more likely to come across clinically, and B, probably more likely to be asked about in your exams. So we'll start off with the epithelium. You're looking at sort of Kogan's, Meesmann, Lisch, and gelatinous. These are the main things that are going to come up in your exams. Map-dot-fingerprint, which is essentially what Kogan's is probably the most common and a corneal dystrophy anyway. But the others are worth knowing and being able to differentiate between them, especially from an SBA point of view, is worth getting your head around. So starting off with Kogan's, like I said, this is also known as map-dot-fingerprint, epithelial basement membrane dystrophy. They're all describing the same thing, and this is the most common dystrophy. So what you get are these sort of map-like, dot-like fingerprint deposits on the epithelium. You get these patterns across it. And to be honest with you, this is actually usually pretty underdiagnosed. So it's not always necessarily the easiest thing to see. They're not always symptomatic. Um, but what essentially happens is you get this like thickening of the basement membrane, you get some proteins kind of slotting in there, and that's what gives you this appearance. Now, usually you'll see this in people's like second or third decades, so they're in their late teens, they're in their early 20s, and they pretty much are asymptomatic throughout life. The main problem that this can cause, and what you'll see is common across the epithelial dystrophies, is that they can cause recurrent erosions because the epithelium isn't really stuck down as well as it should be. So you can end up with recurrent erosions. These are patients that can come in with problems, and if you haven't diagnosed the dystrophy, then you may not always get down to the bottom of what's causing the erosions. You essentially just treat the erosions, and that tends to be pretty good. They tend to have very little in the way of visual symptoms unless they end up with, quite severe recurrent erosions and scarring. But typically, these patients are usually pretty well. Um, Moving on to Meesmann's. So again, not necessarily always well diagnosed. Sometimes it's missed, but you get these intraepithelial cysts, and they're actually pretty regularly spaced throughout the eye, but they spare the limbus. And it looks like almost like a grid of these small cysts that sit within the epithelium, autosomally dominantly inherited. And essentially, again, you're treating these epithelial dystrophies with lubrication. A note here on Lisch dystrophy. So it's very, very similar, but the difference is, so in your exams, you'll be told about this like whirl-like pattern of these cysts, and essentially what it's trying to say is that the cysts you still get these intraepithelial microcysts, but in Lisch they're a bit more densely crowded, usually near the center of the eye, and that tends to be the difference between the Meesmann and Lisch dystrophy. And then finally, when you're looking at gelatinous, this is a bit rarer. You get these sort of deposits on the epithelium. That picture that you can see in the top right is a much more advanced version of the disease. You get these gelatinous deposits. It's autosomally recessive in terms of its inheritance. And the difficulty with this management is that it recurs quite dramatically. So even when you're doing grafts, it can recur. So it's quite difficult to actually get on top of the management of a gelatinous dystrophy. We can then sort of go back a step. Some people sort of group this with the epithelial dystrophies, but really from a microscopic and histological point of view, it's more sort of affecting the Bowmans or anterior stroma with these two. They're very, very similar, and actually most people will tell you that they're almost indistinguishable in terms of your clinical exam. So Reese Buckley, you're getting these gray-white subepithelial opacities. It can be progressive. Again, autosomal dominance, you'll start to see this TGFB1 gene. You're going to see that quite often across the dystrophies. And Reese-Buckler tends to be a sort of worse version of Till-Behnke's. So they get these recurrent erosions. It can get visual impairment, again, because of the scarring, and you're getting these severe erosions. And essentially, you're going to treat these people with lubrication, and you may even consider some laser keratectomy to essentially just burn that anterior layer and stimulate a regrowth in the hopes that it will grow a bit better. So the main difference here with Till-Behnke is that, like I said, it's clinically very difficult to distinguish, but on an electron microscopy, you'll see these curly fibers within the Bowman's layer. It typically is less severe, but again, it's TGFB1. So your stromal dystrophies are probably going to be where most of your questions are going to come from. Most people will have heard of these at least, but remembering how to distinguish between them can sometimes fall through the cracks. So it's worth having a bit of a system in place. And again, I'll go through those at the end. But your stromal dystrophies, these are your four main ones, lots of other types as well, but these are the four things that are going to come up most commonly. And lattice is typically your most common, through to granular and then macular. Schnyder is a slightly different thing. So getting into lattice dystrophy, this is an autosomally dominant inherited condition when you're looking at usually the first two types. There's lots of different types, but across all of them, you're looking at amyloid deposits. So with type 1, you're looking at localized findings to the eye. It's a corneal amyloid deposits within the stroma, which stain with Congo red. You get these branch-like deposits that develop into a lattice, and they tend to spare the periphery. The thing with lattice dystrophy is while it's the most common stromal, it also then recurs at the highest rates when you're looking at grafting these patients. So these are patients who over time may require deep anterior lamellar keratoplasties, and lattice dystrophy tends to recur at the highest rates. Type 2 is again autosomally dominant. This is more when you're looking at both corneal findings and systemic findings. So you may have heard of something like a Meritoha syndrome, where you're basically getting the amyloid deposits within the cornea, but you also get them systemically, specifically looking at the CNS and the cranial nervous system. And then type 3 is a more autosomally recessive type. This is kind of very similar to type 1, but it tends to occur much later in life. And you get these sort of thicker amyloid deposits as well. And again, the TGFB1 gene is what's related here in terms of your main corneal lattice dystrophy. Looking at granular, again, autosomally dominant, again, TGFB1. This is where you get these hyaline deposits. They stain with Mason's trichome. And importantly, with granular, sometimes people mix them up between granular and macular. They mix these two dystrophies up. But with granular, you get these very well demarcated, sort of almost like sugar crystal-like deposits within the stroma. And importantly, the stroma in between these deposits is clear. And that's one of the easiest ways of differentiating between granular and macular. They have lower recurrence rates when you're looking at grafts. With type 2, you're looking at sort of a mixed picture between granular and lattice. So you may have heard of something called Avellino, or it's also referred to as granular lattice, but you'll get features of both. So you'll get both the hyaline deposits and the amyloid deposits, and you'll get both of these, the sugar breadcrumb type lesions plus the lattice lesions as well. So that's generally the thing with granular. And then, like I said, when you compare it to macular dystrophy, it may look very similar, but the stroma in between tends to be quite hazy. Your deposits are they're slightly less demarcated. And another difference here is that macular is actually autosomal recessive in its inheritance. You get these mucopolysaccharides or glycosaminoglycans, and they stain with Alshin blue. Eventually, with macular dystrophy, the entire stromal thickness is affected, which is why sometimes actually with grafts, you may need to do a PK rather than a deep anterior lamellar keratoplasty. While recurrence rates are uh, again common, it's the least common of the stromal dystrophies in terms of its recurrence post grafting. And then lastly was Schnyder, again an autosomal dominance. Now, this used to be called a sort of crystalline keratopathy, but people don't really refer to it as that anymore because actually these crystals are not ubiquitous. So they actually tend to, it's about 50% of patients that will have these crystals. Otherwise, you may just get this stromal haze. And essentially what's happening, it's lipid metabolism gone wrong. So you get these phospholipid and cholesterol deposits within the stroma, which can cause these sort of crystals that you can see, which is what you can see typically here on the right-hand side, but not always. And these patients are usually treated pretty well with excimer laser. So then getting to the back of the cornea, when you're looking at Deschamets and endothelium, Fuchs is probably going to be the thing that you're going to come across most commonly when it comes to endothelial dystrophies, and we'll talk about that at the end. And then otherwise for your exams, you're looking at things probably like posterior polymorphous or congenital hereditary. We'll go into those first before I go into Fuchs. So with posterior polymorphous, again, autosomal dominant, lots of different types of genes that are implicated. There's a few different types of posterior polymorphous, and usually, you've got types one, two, and three, and those genes in order sort of affect types one, two, and three. Um, and usually with posterior polymorphous, they're completely asymptomatic. It doesn't need any treating. You get these sort of endothelial deposits. They're quite subtle. They're easily missed. And typically you get this band-like deposit that you can see in this picture, which comes across here. Like I said, usually an incidental diagnosis and not usually treated, but they can be associated with iris abnormalities, with glaucoma, with Alport syndrome. So there can be other issues within the eye. But an isolated posterior polymorphous endothelial dystrophy is usually not symptomatic and doesn't need any treating. When you're looking at congenital hereditary, or you may have heard of something like CHED, you've got CHED1 and CHED2. CHED1 is quite similar to PPMD, and it's again usually much less severe, but CHED2 is the severe one. And this is where you're going to get these comments or these questions talking about a neonate coming in with a blue-like cornea. So with CHED2, it's autosomal recessive, which is a bit different to the rest of your dystrophies. You get this thickening and clouding because of this endothelial dystrophy. And with CHED2, that tends to present within neonates, so within the first, few weeks of life. Whereas with CHED1, that tends to present later on, so within the first 1 or 2 years of life. Because they get reduced vision, they can also develop an nystagmus. So remember, we can go through this in your ophthalmology, but nystagmus is more likely to occur the earlier in your life you get an ocular abnormality. And these are patients who are usually treated with a keratoplasty. Interestingly, with CHED, sometimes their vision is actually a bit better than you would expect given their ocular findings. But these are patients who ultimately do have some vision loss because it's happening quite early in life. So we'll talk about Fuchs now. So Fuchs is, most of you will have actually come across this and are well acquainted with it. It's bilateral endothelial cell loss, and usually it's sporadic in nature, but there is an autosomal dominant element to some of the cases, and you get this gradual onset blurring over years. And what tends to happen is that it's particularly in the mornings, because essentially you're getting this corneal edema while they're asleep, while the eyes are closed, and then when they open their eyes throughout the day, they get this evaporative dryness, and then the cornea starts to clear. So they get this, clouding that's typical in the mornings. And you've got lots of different things. So in your exams, you may hear something like beaten metal appearance to the endothelium, but essentially you get these guttata. They're completely widespread, and having peripheral guttata can be quite normal in the elderly, but these central guttata is where you start to consider whether or not a patient has Fuchs. Because the endothelium isn't working, you get this edema of the stroma. It tends to then thicken, and then over time, and in the late stages of a Fuchs endothelial keratoplasty, this chronic edema wets the cornea, and you end up with these cysts on the epithelium and bullous keratopathy, and that tends to be then your indication of considering grafting in a patient with Fuchs. So, like I said, conservatively, you might even even a hairdryer to the eyes can help dry out the corneas. Or you may want to consider things like lubrication, hypertonic saline to help draw out that fluid and clear the cornea. And then when you're looking at your surgical options, most of the time with Fuchs now, it's essentially managed with posterior grafting. So either with a DMEC, which is essentially just basically Deschamets in the endothelium, or with a DSEC where you get a tiny, tiny bit of stroma as well. So the other thing to bear in mind, and the other thing that comes up in your exams, particularly in the oral exams, is considerations of Fuchs when it comes to cataract surgery. And that's what we'll go into now. So, with cataract surgery, the main thing that you're worried about with Fuchs is there is a risk of essentially persistent corneal edema after you do the cataract operation. And that risk is essentially higher with patients with an endothelial cell count of less than about 1,500 to 2,000, depends on where you work in terms of what their cutoff is for cataract surgery. And then also, it's more common in patients who already have a corneal thickness that's quite high before you do cataract surgery. And um, most people will suggest that you stage the procedures. So you'll choose to do the cataract first, and that's because cataract surgery can cause an endothelial graft to fail. So you may want to just do the cataract operation first, get that out of the way, and then they may not even need the endothelial keratoplasty. But then after the cataract surgery, if their cornea then fails, you can then consider them for a DSEK or a DMEG. Now, of course, the problem that that faces is that from a refractive point of view, once you do the graft, their refraction can change. So these are patients who need to be counseled on the fact that they may well not be glasses free. For patients who do come in with really thick corneas or with very low endothelial cell counts or with a failed cornea, essentially, you may want to consider doing a triple procedure. So cornea would consider essentially doing the phaco and the graft at the same time. The other things that you may want to bear in mind, and we can go through this a bit more detailed when we're talking about cataract surgery, but these are patients who would benefit from, for example, a soft shell technique, putting some dispersive viscoelastic in the eye while phacoing to essentially protect the endothelium, trying to aim for an ultrasound, as low ultrasound as possible, because it's the ultrasound energy that can essentially damage the endothelium and then risk this persistent corneal edema. So, lastly, I wanted to go through some exam tips. So, one of the things that helped me is basically if you're looking at corneal dystrophies, and one of the things that you may have already picked up throughout this talk, is they're pretty much all autosomally dominant, and there's very few that are autosomally recessive. And the way that I remembered it was there's basically like this juicy mac and cheeses. So, juicy essentially your gelatinous, mac your macular, and cheese is cheddar. Those are autosomally recessive. So gelatinous, macular, and Ched2 specifically, autosomal recessive. The rest are all autosomal dominant. With genes, all the large, so lattice, Avellino, Reese-Buckler. Reese-Buckler is very similar to Thiel-Behnke, so Thiel-Behnke and granular. These are all related to your TGFB1 genes. Otherwise, you just have to rope learn which are the genes. So, for example, UBAD for Schneiders or and for macular, you're looking at your CHST6. So you'll remember these gradually as you do them more and more. But the TGFB1 genes are the ones for that are easy to remember with the acronym LARGE. So lattice, Avellino, which is essentially granular plus lattice, Reese-Buckler and granular, and then Thiel-Behnke is also TGFB1. And the way I remember that is it's essentially the same as Reese-Buckler. And then with your stains, you may have come across this acronym. So Marilyn Monroe always gets her man in LA City. So, you're looking at, if you just go through that, it tells you A, the dystrophy, then what's actually being deposited, and then how you stain it. And that was the easiest way to remember these things. So, these little tricks you can pick up from different question banks and things like that when it comes to trying to remember these for your exams. Clinically, if you're sat in a clinic, you can probably just Google it. But the point is for your exams, your high yield stuff are things like inheritance patterns, genes, and staining, especially for the stromal dystrophies. So it is worth sitting down and just getting these in your head. So, just to summarize, you do want a really close examination of the cornea. It's important to delineate which layer of the cornea is affected. And in your head, having the different layers and the different dystrophies divided that way is usually the easiest way of remembering everything. And then just remember it's stepwise management. Usually, these patients are not necessarily that asymptomatic. For the more anterior dystrophies, you're looking at things like erosions, maybe glare, and then for the posterior dystrophies, which tend to be a bit more visually significant, they'll usually complain of blurring. And you go up the ladder, you start with lubrication. You try to keep the cornea nice and clear, and then later down the line, you start to think about grafting. But the important thing about grafting to consider is the recurrence rates, and that's where they can be limited. So especially with the stromal dystrophies, recurrence rates can be quite high. So you do really want to be considering that before you then go ahead and essentially condemn a patient to a lifetime of close examinations and risk with a graft. So do consider those options carefully before you're then referring over to cornea. And that's what cornea is your corneal colleagues are essentially thinking about when it comes to listing these patients. So thank you very much for joining. Please do remember to fill out the feedback. There's a link in the description, and we will see you at the next one.